Thank you very much, Robin. It's a real pleasure to be here. Let's see if I can maneuver this without killing myself. As I was thinking about what I was going to be discussing this morning, I came across this research that gives evidence that the average adult, listening to the averagely boring presentation, hears about half of what it is said, then understands about half of what he hears, then believes about half of what he understands, and then remembers about half of what he believes. So I rapidly calculated I have about 3.5 good minutes to be audible, understandable, believable, let alone memorable. But I'm going to be focusing a good chunk of my good 3.5 minutes on this remarkable and remarkably unremarkable human capacity, extraordinarily ordinary human capacity, that I will propose to you underlies how we humans hear one another, understand one another, believe or trust in one another, and then access our memories and our minds, our mental states and the mental states of others. Now, in that spirit of accessing minds, one of our colleagues, John Allen, whose contributions to the scholarship of mentalizing include his classic description of excrementalizing, that in a more quantitative way I will be referring to as hypermentalizing, likes to tell the story of one psychoeducational group. We call those explicit mentalizing. Those are educational groups that are part of the MBT model in which we make explicit how we think and how we think about mentalizing as this set of skills and attitudes that we deploy to interpret and understand mental states and the mental states behind behavior in ourselves as well as in other people. So a young woman who is attending this group realizes that she's being invited to access minds, her mind and the minds of others. And she's like, oh, minds! And said, that's a scary place. Oops, this doesn't work. And you're gonna see a panic moment here. The mind is a scary place. So John kind of thoughtfully said, yeah, it's pretty scary. It can be really scary. To which the girl then adds, and you wouldn't want to go there alone. Which I think kind of goes to the heart of what mentalizing is. That is a biologically prepared, a genetically prepared capacity that has evolved to expect a particular signal. This is the signal of attachment of relationships. So it gets generated in relationships. It gets organized in relationships. It breaks down in relationships and can be repaired in relationships. And apropos of repairing, this statement about how scary it is and that you wouldn't want to go there alone also goes to the heart of what mentalizing-based treatment is, which is really an invitation to engage in actually a number of different attachment contexts: individual context, individual therapy, group with peers, the attachment context of the family, each one pushing and pulling different mentalizing strengths and different mentalizing vulnerabilities. And while we engage and invite people to practice mentalizing, we pay attention to when it gets so scary that mentalizing breaks down. What is the particular interpersonal and emotional context in which mentalizing breaks down, and what does it take to bring it back on? That's really it. So, this is not a picture of the Menninger Clinic. As we were trying to make our way from Kansas to the bayous of Texas, It is meant to represent the developmental trajectory of those kids who emerge into borderline personality in adolescence, and make us wonder if the crisis of the moment is going to consume their lives in the flames of that crisis before or after their developmental trajectory leads them down the tubes. That's the developmental trajectory that I want to discuss today, with the notion of how a combination of constitutional vulnerabilities, which may include an exceptional, a heightened sensitivity, a biologically prepared heightened sensitivity and reactivity to social emotional cues, joins with a mismatching environment to generate vulnerabilities in mentalizing that are going to emerge as the symptomatology of borderline personality when the neurodevelopmental changes of adolescence create particular vulnerabilities in the competence of mentalizing. All right, now, just to flesh out and maybe give a little more visceral feeling, just to put in the background of this discussion, and give you a couple of clinical moments. The first one, we're going to call this fellow Joe. And Joe was one of those who, admittedly, this is retrospective information, but all the accounts that we had was that he was one of those kids who was from the get-go exceptionally sensitive and reactive to even tiny mismatches in his environment. And responded with enormous intensity and a very negative mood. He had huge tantrums, which were enormously disorganizing for his mother, who would get very upset when he would have one of his fits. And had to make him stop, and will protect him and protect herself by locking herself in the bathroom and then turning on the shower so the sound of the water will muffle the cries of the baby. Until one time when she couldn't escape, and she found herself in a quasi-dissociated state, pushing a pillow over Joe's face. And she snapped, and I believe that what she kind of said, oh shit, or something to that effect. But she started escaping more and more and left Joe under the care of the father, who was a stay-at-home person who would get drunk and physically and sexually abuse Joe until things fell apart in the family, and he left when Joe was 7. And he was left pretty much to roam the streets, engaging in some petty delinquency. He had fights. He rediscovered alcohol and pot in middle school, and when he was about 8 or 9. By the time he reached puberty, he discovered that cutting and burning himself was really cool. And particularly that it gave relief to the unbearable feeling of feeling nothing. Now, after a questionable suicide attempt, he ended up in our program, and I was his therapist. And we spent initially some time. He was interested in finding out my sexual orientation. Am I a faggot? Am I not a faggot? Who cares if I'm a faggot? I swear to you that at my mentalizing base, I was curious and inquisitive and open and interested in what was in his mind, which he experienced as an unbearable intrusion. You fucking sure you think that you can read minds? I assured them that I couldn't. There was one moment when I think it kind of got me, and so I said, Joe, tell me if I'm right, but it just seemed to me that if you're ever going to share with me what goes on in your head, it will be when it kind of makes sense to you, and not that second before that. And I wish I could tell you that I said, God, Bleiberg, you're so empathic, but if I remember correctly, what he said was something like, fuck off. But in spite of himself, he almost grew to like me. And now we are in the terrain of attachment. And that was a really big problem. At which point he decided to solve that crisis by telling me that he just had it with you, shrink, and that he was going to run away from the residential program where he was staying, saying, I can find where you live. And he was going to find my house and burn it to the ground, but only after raping my wife and murdering my children with intravenous injections of cocaine. A statement that I got to tell you tends to evoke a certain amount of countertransference. And doesn't make mentalizing very easy, so remember that point. All right, so second little clinic is just to keep these things in the background as we get into the discussion of this developmental trajectory. So this is what I call her, I have to remember what I call her, Andrea. Really smart kid who could recite eloquently about her difficulties with attachment and separation individuation, which she had learned over about 8 years of therapy that she had had with 3 previous therapists, which was interrupted for a fairly serious suicide attempt that had her land in Texas. So as we were talking, she loved to tell me about the books that she loved to read. Her favorite one was Infinite Jest by that bitingly brilliant writer David Foster Wallace, who all in jest, but he did kill himself at age 46. And she said for her, things were also a bit kind of in jest, that she didn't really feel much. So when I asked, like, how for real did it feel when, she and I were talking, in a scale where 0 will be like being sort of comatose, where you feel nothing, and 10 is like, you feel it's happening, it just feels real. It doesn't feel like a feeling or a thought, but it's something that is really happening. We were at a 2, on good days at a 3. And so as we were figuring out how to go from 2, 3 to maybe 4, 5, she gave me an example of a 10. And that was a visit with her mom, in which the mother came to tell her that her therapist, the mother's therapist, had told her that she should not listen to Andrea's telling her about how she wanted to hurt herself and kill herself. That was too overwhelming, too destructive, too disorganizing for mom, so she was not going to listen to that anymore. And Andrea felt, as she described it, a white, blinding rage, and told the mom, "You're the worst mother. I want to kill myself so I can escape from you." And as the mother began to crumble, which Andrea could tell because she could tell the little twitching in the corner of mother's mouth, that was the prelude of mother falling apart, Andrea herself stopped feeling, and she went down to 0. She felt nothing. She couldn't even feel that in the corner of her own mouth, she had been biting it and couldn't feel the blood that was coming out until she swallowed it, and then felt that there was something yucky and toxic in her stomach, which she could get rid by purging, which she later were to tell me, purging is perfect. You eat 5 slices of chocolate cake, and you feel bloated, and then you purge, and it's perfect. Mentalizing, I hate. So that shit that you're peddling, I hate. Because she went to a group after that. This is not an explicit, but an implicit group, it's an experiential group, where we actually practice mentalizing as a group with the kids. And she was describing what had happened, and I couldn't stop thinking that she hates me, he thinks that I'm fat and ugly, and he thinks that I'm selfish and nasty. That's excrementalizing. That's hyper-mentalizing, okay? All right. So this is what we're going to do. We're going to review this developmental trajectory. what is mentalizing, how it breaks down, and the principles of mentalizing-based treatment. This is Peter Fonagy's summary of the evolutionary functions of attachment, in which, building on John Bowlby's description of attachment as biologically prepared, it evolved as a procedural pattern of affect, of motricity, of physiology that is non-conscious, that's genetically prepared, evolved to be activated by pre-programmed cues of danger to the survival of the self. Like a loud noise that may signal the presence of a predator, or a drop in our blood sugar, that activates this proximity seeking and signaling that goes like, right? Whose evolutionary value depends on the capacity to evoke a matching, regulating, protective response in another human being. Response that then down-regulates the state of stress and arousal activated by that pre-programmed cue of danger to the survival of the self. And in the context of that, evolution looked like has privileged attachment to provide the specific context that activates the brain mechanisms that allow us to go from this automatic response, like I get threatened and I go into proximity seeking and looking for a match, that automatic response, into flexible, sensitive, context and goal-corrected partnerships that are based on a capacity to represent and regulate affect, effortfully, actively control and regulate attention, and understand and interpret other people's and our own intentional mental states. So how did that happen? First premise, of course, is that this is something that involves, this is a developmental acquisition. It involves something that is biologically prepared, and it involves a particular context of attachment. Little evidence of this is a large study, 1,100 families, Jay Belsky, Avshalom Caspi, and others in the UK, where they follow from birth 1,100 families that have twins. And then at age 12, assess both dimensionally and categorically who were the extreme belonging to the diagnosis of borderline personality in 12-year-olds. Apropos of Eric Hoffman's notion that we can diagnose it reliably. And the interesting thing was that when you break down maltreatment, those who have no family history of psychiatric disorders, maltreatment produces some difference, but not a huge difference from no maltreatment in who is going to be positive for borderline personality. When you put it together, positive family history of psychiatric disorders with maltreatment, the differences become huge and significant. And the mediating factor appears to be theory of mind, what we call controlled mentalizing. So, already discussed that attachment has evolved to be activated by danger, by threats to the survival of the self, and evokes this seeking a matching response that is regulating and protective. So one of the very interesting findings in infancy research, and really cite the work of George Gergely, John Watson at Berkeley. Gergely is now in Hungary, who realized that normal babies are exquisitely prepared to detect the connection between their response, their signal, the and the match of the response of the other. That are able to detect two aspects of this relationship. That the response is contingent, that there is synchronicity, that is timing between my response and the outcome of that response. So I can tell that I am producing this response. The second is that they can detect the attunement, that is the procedural match, how much the affect, the physiology, the gaze in the response of the other matches my own state. Generating what Peter Fonagy called psychic equivalence. That is the notion that there is an equivalence or identity between my brain activity, my mental state, and the mental state of the other. That it conflates what I think and what you think. Does this make sense? Yeah. Okay. I need a response because if I don't get a response, that's trauma. See? Because we evolved to send signals and then get a matching response, if I don't get a response, my brain has evolved to recognize that as you are going to die. So please, match me and respond, or I'm really going to get very anxious. And if you think that I'm boring now, you should see me when I get anxious. So, but this is, huh?
You want finger snaps or what?
No, the gaze. Just look at me lovingly. That's good. Thank you. So, this is a fundamental vulnerability of our evolution, see? That we have evolved to signal and survive on the basis of the other picking up our signal and responding in a matching way. And we can't quite stand not knowing. So remember this notion of the capacity to tolerate not knowing if the other is going to respond. So this psychic equivalence is an effort to eliminate that not knowing, to evoke a response in which the other matches me and I match him or her. That we have the same mind. Yeah, your physiology, your feelings, which is probably built in what we evolved, this mirror neuron system. Okay? So, conversely, if lack of reciprocity, if lack of matching is a threat, it automatically evolves to evoke a defensive response of fight, freeze, or flight. So, we are geared, we're programmed to go from match me, feel what I feel, experience what I experience, have a physiology like mine. If I don't get that, I panic and I go automatically into anger, aggression, anxiety, flight, or I freeze. So how do we switch from this automatic response, this automatic defensiveness, to a flexible way that allows us to figure out when can I trust, how much can I trust, who can I trust, how much, when do I need to go in a defensive mode, and when is it all right to hang on there and engage in a two-way interaction? Well, when we do the microanalysis of baby-parent interaction, starting with the work of Daniel Stern and Beatrice Beebe and Ed Tronick and others who have looked in great detail, how often do you think that the average, okay, motivated, competent, sensitive mom is able to produce that contingent and attuned matching on a moment-to-moment basis to the signals of her baby? Any guesses? 10%. Ooh, I want to talk with you. 60%. 60, okay, we got 10, we got 60. 30. 30, okay, the 30s have it, actually. It's one of every three. which evidently is pretty good if you are hitting in the major leagues. You know, it really gets you in the Hall of Fame. We haven't really checked, you know, empirically how often therapists get their patients. I can tell you that when I get my patients 1 time out of every 3, I think I'm pretty hot that day. Which apparently is, appears to be optimal. This rate of failure appears to be optimal to actually help that transition from requiring an automatic matching, or I go in a defensive mode, to the flexible, goal and context corrected mentalizing. It may not be optimal, however, for the super sensitive babies that perhaps Joe was. And those babies may need a higher level of matching. We've got some suggestion from the work of Stephen Suomi with primates that may apply also to the human primate, that those super sensitive babies left to their own devices grow to be, when we're talking about monkeys now, become socially phobic in adolescence. If you add maltreatment or trauma, they look very much like borderline people. But if instead of giving them an ordinary mom, you give them a super mom, operationally defined as those who can get their babies not 30% of the time, but about 50% of the time, those guys end up being the leaders of the group. And it's an interesting notion that this heightened sensitivity to social emotional cues can be a risk factor under certain conditions of development, but under different conditions of development, it actually can turn into tremendous strength. So, moms ordinarily fail about 2/3 of the time, and that's a good principle to actually know as therapists. The one thing that I do promise the kids and families that I work with, I have very few things that I have certainty about. This is one, that I'm gonna screw up. And I'm gonna screw up often, which actually may turn out to be a really good thing, because those screw-ups are the best opportunities to do treatment. Is repairing those screw-ups and figuring out, wait, so what happened here? That's the best opportunity to actually do treatment. So moms they hold after they miss. They keep the arousal down. They stay open and engaged. This is the basic premises of what we call in MBT the therapist stance. The open, inquisitive, curious, regulating, engaged stance. And then when they get it, when they finally is the moment of contingency and attunement, they don't signal that by imitating the baby. They don't, the response to babies going, is not a mom that goes, back. It's not a good response. However compelled we may feel to respond that way. The response is like, oh, honey, you're so hungry. It's a different behavioral display that captures what Daniel Stern referred to as the architecture, the affect tone, the intensity, the arousal level, in a way that helps, said Stern, shift the focus from overt behavior to the mental state, to what is behind behavior, what you got in your head going that gives direction to your behavior. And does it in a way that is marked. See this, oh honey. It's a universal pattern that we call motherese that appears, and this is another interesting finding of infancy research, that this combination, this context of contingency, the timing of the response, the attunement, the affective procedural matching, and the markedness of the response, the exaggerated, oh honey, with its modulated way of conveying, is an epigenetic signal. It's an epigenetic signal that appears to be important to bring online the brain structures that are going to put the brakes on this automatic disposition to create a perfect match of psychic equivalence. That we got structures in our brain whose activation is like, whoa, just get amygdala, get, okay? And can do that because it activates the coming online of the medial prefrontal cortex and the anterior cingulate that brings about the control of attention. Joint attention is a developmental acquisition about 9 months of age, which allows us to see that what I see is not the same thing that what you see. See, that baby signal by saying, I'm looking there, look there. What I got in my mind, see, is not what is my perspective on what is. And what you got in your mind is your perspective. Now I can influence you so you can see what I see, but you can influence me too. Okay? This is the beginning of representational processing. Processing that is no longer the presentation of experience when what we experience is, but the representation of experience that we can play with. We can turn it around. We can look at it from different views. And the signal that it is okay not to know. Trust. What I'm going to convey to you is now something that you should pay attention, is important for your survival. George Zebra has done really interesting work in which he shows what looks like there is this signaling that seemed to have evolved, you see, as an epistemic or knowledge superhighway that babies need to very quickly acquire a tremendous amount of information about the social environment. And they do so in the context of very specific signaling, and that's the attachment context that says it's okay, and not only it's okay, but actually get going and pay attention and learn, and acquire information, explore, and play with the environment. Learn, among other things, learn how to represent your experience. So, this is a crucial aspect of all psychotherapy. See, when we do psychotherapy, any form of therapy is going to ask patients to take an enormous risk. And the risk is, hang on there. Don't do what automatically you know to do to protect yourself. Take the chance of doing something different. So attachment and this epistemic trust are really going to be essential as part of any effective intervention that is going to engage patients in not only sticking with the treatment, but actually doing what is the effective mechanism of treatment, which is that point in which the patient is prepared to take the risk of exchanging a way of responding automatically that is defensive and sometimes often has been life-saving, to try something different. To try to wait, take a step back. Let's see if we can engage your mind back so we can understand what you're feeling and what the other person is feeling. That's an enormous risk, you see, because we don't know how the other person is going to respond. And for super sensitive people, that can be unbearable. So, those are the parts of the brain. This is the cingulate, medial prefrontal cortex, that come online. And we're proposing that the epigenetic signaling necessary for the coming online of these structures is attachment. That leads to this shared attention mechanism about 9 months that leads to these two modes of processing. Really for about 2 years, they're going to go side by side. They're not really connected. This is what I was referring to as the psychic equivalent mode. that is the automatic looking for a match. Put yourself in my shoes, I will put myself in yours. And we conflate my experience and your experience. Right? Is what happens to Joe's mom when he gets distressed. Is not just his distress, and I'm going to show you actually some evidence of that. It's her distress. Or when Andrea responds, sees her mother collapsing, she starts collapsing. So your experience is my experience. This is the empathizing system in Simon Baron-Cohen's terminology. And this is what more widely is known as the theory of mind mechanisms that we're calling controlled mentalizing. It's the ability to play with ideas. Before they are integrated, this playing is what Peter Fonagy called the pretend mode, where processing doesn't really bridge to real reality. I'm thinking anything. It's what Andrea was doing when she's telling me, it's separation, individuation. It's difficulties that I have with attachment, this infinite jest. It's not for real. It doesn't have any bearing on any connection to her actual feelings and behavior. This integration, this functional balancing between controlled and automatic mentalizing normally happens between 3 and 6 years. So we end up with a two-step system. The first system is automatic, is very fast, is non-conscious, is procedural. It involves this empathizing, mirroring, psychic equivalent system. The second, which is slower, is the control mentalizing that modulates and balances that disposition to create a match of psychic equivalence. So this is the integration about between 3 and 6. But this integration, see, is really designed to fail. It's designed to fail because this component, remember, this gets activated by threats, by increased arousal. So increased arousal activates and potentiates looking for a match. This one, control mentalizing, is activated by arousal up to a point and then is inhibited by arousal. So that's the switch point. Sees the switch point as arousal, which increases attachment seeking, increases. We came to a switch point in which automatic mentalizing prevails while control mentalizing goes to sleep. And that's what we want to do in treatment. We want to bring this back and move this point a little higher. Right. So let me... That's particularly so in what we're proposing is a key developmental antecedent of borderline personality, in which the signaling of distress, that's why I gave you Joe's example, in which the signaling of distress of the baby is enormously disorganizing to the mother. So instead of evoking a mentalizing response in the mother that allows her to say, oh, this playing with the response, to take it in, to contain it, and respond in a way that is actually going to down-regulate the distress and promote mentalizing. The mother goes into fight or flight, which increases stress, right? Because either she becomes abusive and pushes a pillow over his face, or she hides in the bathroom and neglects him, which, as I was mentioning, is really a biologically prepared signal. You're going to die, because our brain is expecting a response to our signals, which in turn is going to activate attachment. See, so we got a vicious cycle in which attachment signals cause disorganization, which increase stress, which increase both stress and attachment, and set the conditions for a readiness. When I go into in an attachment mode, when I get vulnerable, when I need a response from the other, I go very quickly into a hyperactivation of attachment, together with a superactivation of stress. So, of it is that some aspects of experience, and if you think about it, we all have certain aspects of our experience that are not really well mentalized, because, you know, that 2/3 of the time that we fail, well, it's not random, you know, and I'm sure that you all have like really wonderful mothers, but even your moms, there are some aspects of experience, emotional and interpersonal, that for our own biology and experience, we recoil from. So there are some aspects of experience for all of us. There are these non-mentalizing little holes that we all carry with us. The problem here is that the hole has to do with attachment. That it's when I feel like having a relationship that I need a relationship. When I get this non-mentalizing something in me that feels like I need to push it out and treat it the way we treat experience in the state of psychic equivalence. That is something that is physical, that has to create a perfect match in the physical world, whether it's in the world of other people, that is, I have to evoke a match in the other, which I think is what Joe was trying to do with me, where he's trying to generate in me the same rage, the same vulnerability that he feels. So we feel the same. Or you have to create that physical match in your own body, which is, I think, what Andrea was talking about when he says, purging is perfect. You get this perfect match, right? Let me skip this part. Let me show you a little piece of research. This is a study with mothers. We did at Texas Children's Hospital, in which this is Lane Strahan is the principal investigator here. So we show pictures, and I had to tell you, my son took the pictures. So that was his summer internship. Anyway, so we took pictures of the women's babies, and we had pictures of other babies that are not this woman's baby, in 3 basic states: neutral, happy, and distressed. And we obtained the attachment classification of all of these women. And then, while their brains are being scanned with functional magnetic resonance, they are exposed to these pictures. Okay? And the findings are really interesting. Really significant differences between the mothers who had a disorganized attachment and those who had a secure attachment. Medial prefrontal cortex, it goes to sleep in these women who have a disorganized attachment when they see their baby in distress, compared to the securely attached women. The insula, which gets activated in this visceral way when your body is in danger. See, I think that this is what psychic equivalence looks like in the brain. Intense response in the disorganized mothers, no response in the securely attached moms. All right. Well, in the interest of time, I'm not going to tell you about the nucleus accumbens, but it's really interesting. So the point of it is that We're gathering some evidence actually that this switch actually happens, in which that point in which control mentalizing goes down the tubes in a particular attachment and arousal context actually switches. So it takes less arousal for this to happen. But more significantly, it takes a particular context. And we're proposing that that context is the context of emotionally invested relationships. So I think I'm going to run out of time. So I did want to say that there are particular changes in adolescence that for those who come into adolescence with a particular vulnerability in their mentalizing capabilities in attachment, make them especially vulnerable to the emergence of psychopathology in general, and in particular to borderline personality. There is, on the one hand, all the sexual hormones of adolescence actually increase the density of oxytocin receptors, that's the hormone of attachment, in the nucleus accumbens, in the amygdala, so there is a greater hunger and responsiveness for attachment and for the emotional response that goes with it. At the same time, there is an active process of pruning in the parts of the brain that have to do with control mentalizing. So the control part is really going through a process of reorganization, while the other is actually more intense. And for kids who come to this point with vulnerabilities, with that experience of non-mentalizing attachment experience, that's a very explosive combination. So that's the hypothesis, that increases the vulnerability to adaptive breakdown in general, but in particular to emerging borderline personality disorders. That will involve the breakdown of mentalizing in emotionally charged attachment context and the reemergence of the modes of mentalizing that precede full mentalizing. I do want to mention this later point, and I did make a little quip about how hard it is to mentalize when somebody's telling you they're going to burn your house and rape your wife. Because in fact, non-mentalizing evokes non-mentalizing. This is not countertransference. This is a generic response. Our brain has evolved to recognize that when somebody is mentalizing, that signals they have you in mind. They are not going to kill you. When somebody approaches you in a non-mentalizing way, that signal they are not recognizing you as a human being. There is no inhibition, that you are a thing for them in that moment. And we all have this response to non-mentalizing, which is that we stop mentalizing. So, non-mentalizing and the coercive procedural behavior that goes with it evokes non-mentalizing in others and creates those vicious cycles that reinforce non-mentalizing and the breakdown of mentalizing, right? This is what happens in families, this is what happens in schools, this is what happens in treatment. So a key component of mentalizing-based treatment is really to create a context of supervision, of peer sharing that supports the mentalizing of the treaters, that allows us to keep that capacity not to enter into the non-mentalizing cycle that is going to perpetuate and reinforce non-mentalizing. All right, so I have like 5 minutes? Okay, so all modes of mentalizing-based treatment, from this common trunk of mentalizing-based treatment that Anthony Bateman and Peter Fonagy originally outlined. We have now generated a number of different protocols, including a protocol for adolescents and a protocol for families. They all have common objectives, and the objective that we use is engage in managed crisis to shift those non-mentalizing cycles to mentalizing interactions that we take about 3 to 6 weeks. This is sometimes what we do on an inpatient or residential setting. We provide targeted treatment for all of the neuropsychiatric problems. It's following that fundamental principle that Picasso outlined and said that good artists or good clinicians borrow, and great artists or great clinicians steal. So unabashedly, taking on all the really great protocols out there, including DBT and CBT and pharmacological interventions that specifically target either particular symptomatology or particular conditions, all of which exacerbate non-mentalizing and are exacerbated by non-mentalizing. And as we reduce self-damaging, threatening, and suicidal behavior, we seek what is really more specific and deliberate about mentalizing-based treatment, which is to promote mentalizing and practice it in the very specific context in which it breaks down. Is to get back to those conditions when you feel vulnerable, you're about to turn off your minds. Hang in there. Can we turn it back? Can we now practice keeping your mind on? To initiate virtuous cycles, this is the rehabilitation of mentalizing, which we think we got some empirical evidence that it takes about 12 to 24 months. This is the process that I'm not going to tell you about. I wanted to, I have 5 more minutes.
Yeah, we'll just save your questions.
Okay, you cannot ask me questions.
Just 5.
Well, you want me to stop and you can ask questions or keep talking?
Keep talking.
All right, okay. This is the battery that we use at the Men and Adolescent Treatment Program, and which we follow at discharge, 6 months, 1 year, and 18 months. And there is a reference there where you can find a full description of the measures. And what I wanted to point out here, in addition to, there are measures to diagnose borderline personality and personality disorders, both dimensionally and categorically. That is the childhood interview for DSM-4 and the more dimensional borderline personality feature scale. But I wanted to show you about measuring mentalizing capacity, in particular one of the ways, which is this movie for social cognition, The Mask. And the relationship of that with the difficulties in emotional regulation scale. So the mask looks more at automatic, implicit, internal mentalizing. And just to give you a sample, this is a movie that you show to the kids, and it's a 15-minute movie, and we stop it and ask them, what are they thinking? So, one scene, for example, Cliff knocks in the door, and Sandra opens the door, and Cliff says, "Oh, did I surprise you?" And say, "Oh, your hair looks great. Did you do something to your hair? You look terrific." And Sandra goes, "Oh." Before she can answer, say, "Oh, that looks really very classy." So what is Sandra thinking? And what this measures is those who don't mentalize very much. "Oh, my hair doesn't really look that nice." Those who under-mentalize, she liked that he said that her hair looks nice. Those who hyper-mentalize, which is a form of psychic equivalence. This is the supersensitivity. And this is the one who says, "Why is it coming on to me? What is it trying to do?" Okay? And then there is accurate mentalizing. It says she was, pleased, but somewhat baffled and confused and uncertain about what this was about. So, very strong correlation, and we had 132 admissions that we ran through this whole battery, and about 20 that were not counted for various reasons. So we had about 110 kids, and 25% met diagnostic criteria for borderline personality. the correlation between hypermentalizing and borderline personality features was very, very strong and very distinct from other diagnoses. Correlation also with emotional regulation difficulties and mentalizing. The point of this is that what we find is the evidence of how the hypermentalizing is mediated by difficulties in emotional regulation to correlate with the symptomatology of borderline personality. Oops. Okay. Well, I was going to show you some additional evidence, but I'm going to skip that part. I will only say that the protocol of mentalizing-based treatment with adolescents on an outpatient basis, which includes weekly sessions of individual mentalizing therapy and monthly sessions of family therapy, was tested by Trudy Russo in London. Had 80 kids, comparing them with treatment as usual, very robust evidence of effectiveness. Our findings were very interesting in terms of having a very strong correlation between a drop in hypermentalizing and a reduction in borderline symptomatology. So I think that we're beginning to make some headway into providing some tools to help kids and families really break the grip that anxiety, supersensitivity, anger, misery has really, kept a grip on their loneliness and their misery. Thank you very much.